Welcome to the deep dive. Today we are tackling a major clinical chapter from medical-surgical nursing.
That's right.
A real deep dive into sexually transmitted infections, STIs. We're aiming to synthesize the essential concepts for patient care.
Yeah, our mission here is really to take that dense clinical text and, make it an actionable guide.
Right.
We're pulling out those core concepts that define high-quality nursing practice in what can be a very sensitive area.
Coordinated, confidential, comprehensive care. That's the goal.
Exactly.
And the source material, it anchors everything around three key concepts. These are kind of the lens we look through. Sexuality, infection, and pain.
Those are the big three. And the example that really ties them together, our main focus point, is pelvic inflammatory disease, or PID.
We'll get to PID later, but first, what's really striking is how critical that initial nurse-patient interaction is.
It really is.
Yeah.
Because STIs like chlamydia, gonorrhea, syphilis, these are nationally notifiable diseases.
Meaning they have to be reported to public health.
Correct. So the nurse has this foundational role, sort of a balancing act.
Balancing reporting with strict patient confidentiality.
Precisely. And establishing a safe, private, non-judgmental environment from the get-go. That trust is paramount.
Okay, so let's unpack the basics. Transmission, we usually think intimate contact, right? Oral, vaginal, anal.
That's the primary route, definitely. But it's easy to forget STIs aren't exclusively sexual.
Good point. What else?
Well, the sources remind us about non-sexual routes, too. Things like parenteral exposure, infected blood,
Okay.
fecal-oral routes for some infections, and also transmission during pregnancy or birth, intrauterine and perinatal.
Got it. So broader than just sexual contact. Now, risk factors. Who's most at risk?
The classic profile involves things like multiple or anonymous partners, a history of previous STIs, also 5D drug use, or having sex while using drugs or alcohol that impair judgment.
But we need to look beyond just that profile, don't we?
Absolutely.
Yeah.
This brings up really important points about disparities, physiological and demographic ones.
Like how women are more vulnerable.
Yes. Anatomically, the vaginal mucous membranes offer a large vascular surface area, making infection easier.
And they often don't show symptoms, right?
Exactly. Asymptomatic infections are much more common in women. This delays treatment.
And allows for those serious ascending infections leading to worse complications down the line.
It's a major issue. And we also see significant healthcare disparities among racial and ethnic groups.
And for LGBTQ plus patients as well.
Definitely. For instance, men who have sex with men, or MSM, carry the greatest risk for primary and secondary syphilis.
Okay.
And transgender women face significantly higher rates of HIV infection compared to other groups.
So the nursing safety priority here is crystal clear.
Assess everyone, regardless of age, including older adults. Assess their risk and provide education tailored to them.
Because the stakes are incredibly high. Untreated STIs aren't just, a temporary problem.
Not at all. We're talking about severe long-term consequences. Infertility, ectopic pregnancy, chronic pelvic pain.
Even cancer with HPV, and potentially death.
Which makes prevention safer sex practices the absolute crucial intervention.
So what are the evidence-based methods?
Using latex or polyurethane condoms consistently and correctly for genital and anal sex.
And barriers for oral contact?
Yes, using dental dams or other barriers for oral, genital, or oral anal contact. Also, abstinence, mutual monogamy, reducing the number of partners.
Basic but effective strategies. Now, there's a really crucial clinical alert in the text about spermicide.
Oh yes, this is vital. Spermicides containing nonoxynol 9.
They're not effective against STIs.
Not proven effective, no. And worse, they might actually disrupt the vaginal lining.
Which could increase the risk for HIV transmission in women. Wow.
Exactly. So discouraging their use for STI prevention is a really important teaching point for nurses.
Okay, let's transition now. Let's dig into some specific infections, starting with a viral one. Genital herpes, or GH.
Right, caused by HSV1 or HSV2. And the key thing here is it's viral, which means it's incurable.
It doesn't go away.
Nope. It lies dormant in the sacral nerve ganglia. So recurrences aren't new infections. They're reactivations of the virus already there.
Triggered by things like stress, fever.
Even the menstrual cycle, yeah. And it's worth noting, HSV2 tends to recur and shed virus asymptomatically more often than HSV1.
Okay, so what do patients actually experience? What are the cues?
Often there's a prodrome, a warning sign. Tingling or itching maybe 1 or 2 days before the lesions pop up.
And then the lesions themselves.
You get these characteristic clustered vesicles, little blisters. They rupture and become really painful ulcerations.
Painful, hitting that core concept of pain. And they take a while to heal.
Yeah, typically 2 to 6 weeks.
How's it diagnosed reliably?
Best way is a viral culture or a PCR assay taken directly from the lesion, ideally within 48 hours after it appears.
And management. Since it's incurable.
Management focuses on reducing the severity and frequency of outbreaks using antiviral medications, aciclovir, valacyclovir.
But they don't eliminate the virus.
Correct. They don't cure it. We can use chronic suppressive therapy for frequent outbreaks, but even that doesn't stop all viral shedding.
So nursing interventions focus a lot on comfort.
Definitely. Pain management is key. Analgesics, topical sprays, recommending sitz baths to soothe the area.
And what about the sexuality aspect? This must be tough for patients.
It really is. The critical teaching point and action alert in the text is abstaining from sex when any lesions are present.
And using condoms even when there are no lesions.
Yes, always. Because of that risk of asymptomatic viral shedding, patients need to understand that risk remains.
Okay, next up, syphilis. This one sounds complex. A bacterial systemic infection.
It is, caused by the spirochete treponema pallidum. And if it's not treated, it progresses through 4 pretty distinct stages.
Let's walk through them. Stage 1.
Primary syphilis is marked by the chancre. It's typically a single, painless, firm, sort of weeping ulcer.
Where does it appear?
Right at the site where the bacteria entered the body. Usually shows up about 3 weeks after exposure.
And it's highly infectious at this stage.
Very infectious.
Yeah.
But here's the really tricky part. The chancre heals and disappears on its own within a few weeks, even without any treatment.
Oh, that sounds dangerous. Gives a false sense of security.
Exactly. But the bacteria haven't gone away. They've spread systemically.
Leading to stage 2.
Right, secondary syphilis. Now you get a systemic illness. Flu-like symptoms, malaise, fever, aches.
And the rash. I've heard about the syphilis rash.
Yes, a very characteristic widespread rash. You often see it on the palms of the hands, soles of the feet, and the trunk.
And sometimes other lesions, too.
Sometimes you see these moist, weeping, grayish-white lesions called Condylomata. They're also highly contagious.
Okay, what happens if it's still not treated?
Years later, potentially decades, it can progress to tertiary or late syphilis.
And this affects major organs.
Yes. It can damage the cardiovascular system or the neurological system, leading to things like progressive dementia, blindness, paralysis, really severe outcomes.
So treatment is critical. What's the standard?
For early stages, the gold standard is benzathine penicillin G, given as an intramuscular injection.
Now, diagnosis seems important here too, especially for follow-up. There are different kinds of blood tests.
Yes, and this is a crucial distinction nurses need to explain clearly. There are non-treponemal tests, like VDRL or RPR.
What do those tell you?
They measure disease activity. Their levels usually go down after successful treatment, so we use them to monitor response.
Okay. And the other type?
Those are troponemal antibody tests, like FTA, ABS, or TPPA. These detect antibodies specific to the syphilis bacteria.
And the key point about these?
They typically remain positive for the patient's entire life, even after they've been successfully cured.
Wow, okay, so a positive test later doesn't mean the treatment failed or they're reinfected.
Not necessarily if it's a treponemal test. That's vital counseling, so patients don't get confused or anxious about future test results.
Good point. And there's a reaction sometimes with the treatment itself?
Yes, another safety watch out. The Jerisch-Herxheimer reaction.
What's that?
It's a temporary, usually benign, flu-like syndrome fever, chills, muscle aches that can happen within about 24 hours of getting the penicillin.
What causes it?
It's thought to be caused by the massive release of toxins from the dying spirochetes.
So it's actually a sign the treatment is working, in a way.
Kind of. But patients need to be warned it might happen so they don't panic or think it's an allergic reaction and stop treatment. It usually resolves on its own.
Okay, let's shift gears to another common one. Condylomata Acuminata, better known as genital warts, caused by HPV.
Right, Human Papillomavirus. And this one's critical because certain high-risk strains, particularly type 16 and 18, are strongly linked to cancers.
Cervical cancer, obviously, but others too.
Yes, also penile, anal, and oropharyngeal cancers. The link is very well established.
What do the warts actually look like?
They usually start as small, flesh-colored papillary growths. Sometimes they can grow and coalesce into larger cauliflower-like masses.
And treatment. Can we cure HPV?
Ah, that's the key thing. Treatment focuses solely on removing the visible warts. There are topical applications, cryotherapy, surgical removal.
But these treatments don't eliminate the underlying HPV infection itself?
No, they don't. The text is very clear on this. There is no cure for the HPV virus. That means the warts can, and often do, recur even after treatment.
So prevention is paramount here.
Absolutely. The number one strategy is vaccination with the HPV vaccine Gardasil 9, ideally before sexual activity begins.
And for women, regular screening.
Yes, adhering strictly to the recommended cervical screening guidelines, Pap tests, and HPV co-testing, typically for women ages 30 to 65, though guidelines vary slightly.
All right, now let's tackle the really common bacterial STIs, chlamydia and gonorrhea. We often discuss them together, right?
We do, mainly because co-infection having both at the same time is incredibly common.
Makes sense. So chlamydia first,
Yeah.
caused by C. trachomatis. It's the most frequently reported bacterial STI in the U.S.,
That's correct, and a big reason for that is it's often the silent offender,
meaning no symptoms.
very often asymptomatic, especially in women. This is why it causes so many problems like PID down the line, because people don't know they have it.
If symptoms do appear, what might they be?
Maybe some mucopurulent discharge from the cervix or urethra, or perhaps some dysuria, painful urination, but often nothing.
How's it diagnosed then?
Diagnosis is very effective now using nucleic acid amplification tests, or MADITs. These can be done on urine samples or swabs,
Very convenient. And treatment.
usually straightforward with antibiotics.
Oh.
A single dose of azithromycin or a week-long course of doxycycline.
Now, you mentioned something called Expedited Partner Therapy, EPT. Tell us about that.
Yes, EPT is a really important public health strategy, especially for chlamydia, and sometimes used for gonorrhea too.
How does it work?
It means when a patient is diagnosed, they're also given medication or a prescription for their sexual partner.
So the partner can get treated without having to come in for an exam first.
Exactly. It helps break the chain of transmission much faster by treating partners who might otherwise not seek care promptly.
Seems very effective for chlamydia with those oral antibiotics.
Highly effective. Now, gonorrhea caused by N-gonorrhea is a bit different. It can also be silent, but maybe less often than chlamydia.
What are the symptoms if they occur?
Often discharge and dysuria again. In men, the discharge with gonorrhea is often described as more profuse, maybe yellowish green, compared to chlamydia.
And gonorrhea can cause complications beyond the genitals too,
Yes, it can lead to disseminated gonococcal infection, causing things like joint pain, skin rashes, and antibiotic resistance is a growing concern.
which affects treatment.
It does. The current standard treatment is combination therapy to combat resistance. An intramuscular injection of ceftriaxone plus an oral dose of azithromycin. Treat for both potential infections.
Okay, so you treat for chlamydia even if only gonorrhea is confirmed.
Generally, yes, because co-infection is so common. You give the ceftriaxone shot and the azithromycin, or doxycycline.
And how does this affect EPT for gonorrhea?
Well, it makes EPT less straightforward. You can't just send the patient home with an injection for their partner.
Right.
So while EPT is sometimes attempted using an oral antibiotic alternative, like cefiximir for the partner, it's generally considered less reliable for gonorrhea compared to chlamydia because the injectable ceftriaxone is preferred. Partner referral for full treatment is often necessary.
Okay, let's bring it all together now and circle back to our core concept, exemplar. Pelvic Inflammatory Disease, PID. This really highlights the infection and pain concepts.
It really does. And it shows the severe consequences of untreated, often ascending STIs.
So what is PID pathologically?
It's an acute syndrome. It involves infectious organisms, most commonly chlamydia or gonorrhea, traveling upward from the cervix and uterus into the upper genital tract.
Infecting the fallopian tubes?
Yes, infection of the fallopian tube salpingitis is the most common and damaging aspect. But it can also involve the ovaries and pelvic peritoneum.
And the consequences are serious.
Devastating, potentially. Chronic pelvic pain, infertility due to scarring in the tubes, and a significantly increased risk of ectopic pregnancy later on.
What's the main symptom patients report? What's the biggest cue?
The most frequent symptom is lower abdominal or pelvic pain, often described as dull or aching. That's the hallmark.
Are there other cues nurses should look for?
Yes, things like irregular menstrual bleeding, painful urination, dysuria, maybe an increase or change in vaginal discharge, and definitely dyspareunia.
Dyspareunia, painful sexual intercourse,
Correct.
directly hitting that sexuality concept again.
Absolutely. Risk factors include being young, usually under 26, having multiple sexual partners, a history of PID.
And surprisingly, vaginal douching.
Yes, Douching is a significant risk factor because it can disrupt the normal vaginal flora and potentially push bacteria upward.
How is PID diagnosed? It sounds like it could mimic other things.
It can. Diagnosis is often based on clinical criteria, the
No.
presence of pelvic or lower abdominal pain, plus findings of tenderness on pelvic exam. And you absolutely need to rule out other surgical emergencies like appendicitis or ectopic pregnancy.
Labs are involved too.
Yes, checking for white blood cells, inflammatory markers, and confirming the presence of Gonorrhea or C. trachomatis. And a pregnancy test, HCG, is essential.
So nursing management, we're fighting the infection and managing the pain. How's it treated?
For uncomplicated PID, meaning not severely ill, treatment is usually outpatient with broad-spectrum antibiotics, often a combination, for a full 14 days. It can be oral or involve an initial parenteral dose.
And there's a specific position recommended for rest.
Yes, this is a key nursing action safety point. Instruct the patient to rest in a semi-Fowler position.
Why semi-Fowlers?
It uses gravity to help promote pelvic drainage downwards and can help prevent the accumulation of pus higher up in the abdomen, like near the liver.
Makes sense. And what about sexual activity?
Absolutely crucial. Avoid all sexual intercourse for the entire 14-day antibiotic course and until all symptoms have completely resolved, and partners must be treated.
When would someone need to be hospitalized for PID?
There are specific criteria. If a surgical emergency can't be ruled out, if the patient is pregnant, if they're severely ill, high fever, nausea, vomiting, unable to tolerate oral meds, or if there's evidence of a tubo-ovarian abscess, a TOA.
That sounds serious.
It is a collection of pus involving the tube and ovary. Requires more aggressive management.
Self-management education seems critical here.
Absolutely vital. Emphasize completing the entire course of antibiotics, even if they feel better.
And any interactions to watch for?
Yes, warn them to avoid taking antacids containing calcium, magnesium, or aluminum close to the time they take certain antibiotics, like doxycycline or fluoroquinolones, as it can decrease absorption.
And again, treat all partners.
Always. Reinforce that all sexual partners from the past 60 days need evaluation and treatment to prevent reinfection and further spread.
So if we try to synthesize this whole deep dive, it feels like the core nursing actions go way beyond just giving meds or knowing the microbiology.
They really do. It comes down to communication and support, helping the patient navigate the emotional and psychosocial impact of an STI diagnosis.
Which can be significant. Shame, fear, relationship issues.
Exactly. Maintaining absolute confidentiality, building trust, providing that non-judgmental space is fundamental.
And then the health teaching has to be crystal clear.
Crystal clear. Everything from correct condom use to the importance of follow-up appointments to why they absolutely must complete the full course of antibiotics.
Yeah, it seems like that educational piece, that advocacy, is maybe the most powerful tool we have.
I think you could argue that when you
Yeah.
consider how common STIs are and the severity of potential long-term complications, infertility, ectopic pregnancy, cancer.
Yeah.
Then the nurse's role as an effective educator, a trusted advocate, and a non-judgmental supporter really becomes maybe the most critical intervention in our entire public health strategy for breaking these chains of transmission.
That's a powerful thought to end on. The nurse as the cornerstone of STI prevention and care through communication and support.
It's a huge responsibility and a huge opportunity to make a difference.
Excellent point. Thank you so much for walking us through this complex chapter.
My pleasure.
And thank you all for joining us on this deep dive.
Yeah.
We hope these clinical shortcuts and insights prove truly invaluable in your practice.